Jen, thank you so much for joining us today because I know you have a super busy schedule, and I'm just really excited that you're here to talk about the project been working on for the past, I don't know, year, 18 months, 2 years. It's been a while. But for those of you who don't know Jen Runkle, because I literally talk about her all the time, she's been a longtime collaborator with the network. And in fact, I think we met about 7 years ago, Jen, because I was doing the math in my head before this conversation.
Hmm.
And I first met you when I had an 8-week-old baby who's about to turn 7. And that was pre-COVID times, which means we've basically been working together our entire lives.
It's
And
so true.
but we have worked together on many data and research projects over the past almost 7 years. Jen is an epi genius. She's a great collaborator. She's a colleague, dare I say, friend. And the WHO basically has you on speed dial, which, if that were me, I would open every conversation with that fact. So you should put that in your email signature. And then you're such a fan of the work that we do at the network. You bring so much spirit and energy to the research and getting us across the finish line of those research projects. I like to think of you as the 12th man to our WNC Health Network football team, which is my one and only Seahawks reference during this conversation. Go Hawks. So, Jed, I don't know if there's anything else you want to add. That was the non-professional lead into this conversation we're having today. But if you want to do like titles and where you work, go ahead.
Uh, Joe, I'm like, whoa, I feel so good. Look, with that introduction, I'm a yes to you always. I am one of the WNC Health Network's biggest fan, here to play anyway, anytime with you guys. And I think we both share like we're data nerds, right? Like love looking at the data. What can it tell us? What can it tell us in ways that are going to really improve the health and well-being of WNC? So, fantastic introduction. And yeah, I don't know if I would take it as far as an epigenius, but when I was coming up the ranks, I was like, I want to be a medical doctor. And I tried all that, and I would go and, do my little mini medical school and like almost pass out when I saw blood. And I took a long step back and was like, I think epidemiology is like the more efficient many patients, one job, one or two mathematical models. And so as you mentioned, am an epidemiologist, but most of my work is really focused on bringing the environment and how humans interact with their environment and how that impacts their health kind of to the fore. So, delighted to be here and talk more about this work that we have been thinking about for many, many moons and that we've been kind of getting off the ground for the past year under all kinds of difficult circumstances.
Yeah. So the project that we're talking about specifically today is the work that we did to support the integration of climate and health risk data into the 2024 community health assessments across our region, which is the 16 westernmost counties in North Carolina. And we had a really encouraging response. We had about 81% of our counties included climate and health data, and that's 13 of our 16 counties. So very excited. We were really hopeful because, as Jen mentioned, we've been thinking about this for a while. Post 2018, so I met Jen, just after we were planning on doing climate and health as like the big push in 2021 CHAWS, but then we had COVID, we had George Floyd, we focused on COVID and racism and discrimination in our community health assessments. And then kind of the eye on the horizon being 2024 is the year that we're going to make it happen. And so there was a long, like, talking about it, thinking about it before we were able to do it in 2024. Fortunately, the Eastern Band of Cherokee Indians, the tribe included the climate module the year before we did in their tribal health assessment. That was so helpful. I know, Jen, you kind of worked on that project as well. We were able to learn from them. So I felt like it was possible that we could pull this thing off. And then I think in the end we did. particularly because of the things that have been happening in the region related to climate since like the 2016 fires. That's right after I started at the network. Flooding, Helene, the most recent winter storm. Like we're just seeing them more and the effects being worse. So I'm wondering, Jen, I know some folks might be surprised that we were able to get so many of our counties to include climate data. And I'm just wondering from your perspective, why you think there might be such a strong uptake or why the time is now for folks to start including it.
Yeah, that's great. And I wanted to echo your shout out to Sheena and Mark at the Public Health and Human Services with the Eastern Band of Cherokee Indians. They've been front runners in
Leaders.
trying
Yeah.
leaders, absolutely, and bringing climate kind of full scale into this thaw process, tribal health assessment. Um, I think I think over the last decade, it's funny, I've been doing this research for a decade, which feels so weird. But back in like 2014, 2015, Margaret Chan, the former director of the WHO, really put a pin in climate change as the leading public health threat of the 21st century. And when she said it, I'm like, yeah, I can kind of see it, but I was still sort of getting on board with that, thinking about racism, child maltreatment, financial concern. I mean, there's a host of public health issues. And I was like, man, we're going to have a hard time bringing climate to the fore. But I think in that, Joe, just as you've mentioned over this decade since, there's been increasing awareness among public health departments, practitioners, even clinicians about, yes, extreme weather, climate disasters. They're increasing it in frequency and intensity, and it's not just something I'm watching on the news, it's happening in my backyard. So I think it's really a combination of increasing awareness, like even public health is sort of trying to bringing this to the fore. I think nationally, we haven't been able to escape it. And just here locally, that series of observed events, it's just undeniable. So I think in many ways that in that huge uptake really and bringing climate into the CHA is just characteristic of like there's full like buy-in and awareness. The awareness and the risk perception are there here in our region. It's super rad.
Well, and speaking of risk perception, we included that one question on our region-wide survey about do you believe in the that climate affects health risks? I can't remember the exact language, and it was 74%, nearly 8 out of 10 folks think that there's this strong connection between climate and health. And
I mean, exactly, Joe. Like, so that 7 out of 10 residents, what upwards of like 5,400 residents, which is a representative sample of all of the 16 counties in our region, agreed that climate change is happening here and now and impacting the health and well-being of WNC residents. So it's trickled down from public health leaders, clinicians, all the way down to everyday residents because they're seeing this issue in their backyard.
when we look at it disaggregated too, across all demographics, it's like over 70% of folks in all the age groups, genders, socioeconomic status, race, and LGBTQ plus status all believe that there is this connection between climate and health. So it's everybody.
It's everybody. And then Helene brought that full circle, which I'm sure we'll get to later.
Yeah. Now, when climate data is included in the job, because it hadn't, this is the first year, and most likely, some of the first community health assessments in the certainly the region, probably the state, maybe even the nation. How does it start to change the conversation when we include and put this climate data into our community health assessments?
Well, I think first and foremost, the community health needs assessment is a trusted existing process that brings both public health and hospitals together. So this is already trusted regionally. It's a no-brainer way because data is already being collected on health outcomes, social determinants of health. So it's a really efficient and practical way to actually bring climate data into existing processes, public health infrastructure. So I think one of the key advantages is that when you bring this climate data into this process, it allows local and regional decision makers to begin to develop a shared language and to begin to kind of make those connections what's happening within their counties and how this is really a regional issue. So I think at just first pass, it increases awareness and education, which are two um, foundational things that have to happen in order to begin that health and priority planning piece.
Yeah, because if it's not in the community health assessment and we don't have the data, it doesn't get included in the entire process of looking at health priorities, looking at strategies, and those eventual community health improvement plans that come out of that, which we're not talking about today, but a
Yeah,
big
and I
piece.
mean it's a whole adage, right? What gets measured gets monitored, or what gets measured gets modeled, gets monitored, and decisions made. And so just by facto of folding in climate data in this process, we've jumped 10 steps ahead to kind of get ahead, like to be more proactive than reactive when these events happen.
So what do you think the next step is? So we've included it. Now
Yeah,
now where do we go from here?
I think so. Yeah, I think just including climate data is that first step. The next step is to begin to fold in that climate data with health trends, to bring these connections on how extreme heat is impacting residents who have existing cardiorespiratory conditions, how um, looking at how drought may impact mental health for those in agricultural communities. And so I think it is just the next step is to thread that needle and overlay the climate data with health trends and start to identify what are these priority areas, geographic areas, and what are priority populations that we need to have at the forefront as we begin to be even more strategic around preparedness and adaptation efforts. And that's where we're a little behind because of Helene and some of the federal changes last year, but that's really the next step in our work is to model climate trends and identify those unique climate health associations and those at-risk groups.
I think we've kind of started a baby project. Well, it's not a baby project. It's a very large project with the mental health communications campaign that's coming out and kind
Mhm.
of tying that to post-Helene mental health and looking at those groups that are most affected. And they are doing like very intentional listening around those most affected groups for mental health campaigns. So
Yeah.
we'll see how that goes and report back on it.
Yeah.
Um,
And mental health is a big ticket item when you think about climate change. There's varied ways in which climate through extreme heat, extreme weather, hurricanes, heavy precip, both directly and indirectly impact health. But we know that climate change doesn't act in a vacuum, right? It just makes worse or acts like a threat multiplier and makes those existing disparities or social stressors so much worse. So just like some of that research that you guys have led, connecting that cyclical relationship between those who are financially constrained and have poor mental health, we know that climate change makes food insecurity worse, housing insecurity, stress, social support. And so I think one of an additional benefit is we have this data in the CHA and we can begin to disentangle these relationships.
Jen, I wanted to move to a question that I get a lot of, or a question that we get quite a bit, which is access to data, because access to data has changed over the past 12-ish, 12 plus months. And do we still have access to consistent climate data. Where is it currently coming for? Is it stable access? I think is a big question that folks have. What is it going to look like in 2027 when we try and do this again?
Yeah, that's a great question. Most of the data that we used for the CHA came from NOAA National Centers for Environmental Information here in Asheville. Those it's hard, Joe, because over the last 12 months or so, you're right, there have been significant alterations, redactions, or deletions of hundreds of climate data sets that are federal government resources. There have been a number of professional organizations at all working feverishly to store, archive. It's a little bit of a mixed bag, but I think for the key indicators, precip, heat, drought, hurricane associated flooding, etc., the data remain stable. And my hope is that we can continue to see that in 2027. It's just a little bit of it's a wild time to be in science, and cl studying climate
Mhm.
change, as well as public health.
So I'm going to segue here into Helene because I think what we learned with Helene was that no matter how much data we did have for predicting what could happen, we saw what can happen when we get that kind of tropical storm in the region. Um, what did what did Helene reveal that the data might not have shown us?
I feel embarrassed because, I'm the environmental epidemiologist. I've been studying climate disasters for a very long time. Helene wrecked me. It wrecked what I know about these events. It's so personal, and I'm still
Still
unpacking,
processing. Yeah.
still processing. I think we all are. I don't know. It's just huge, but a lot of it's internalized because I'm like, gosh, it's been a year and some change, like what, 4 or 5 months. So it's been like 16, 18 months. I don't know. I can't do the math. We're in such a precarious place. I think we have received 11% of federal dollars to address FEMA recovery. And when you think about Hurricane Maria in Puerto Rico, a year after the event, they had upwards of 70% of federal recovery dollars. After Hurricane Katrina, a year after the event, had more than 80% of recovery dollars. So there's so much work to be done. Helene is not over for this region. And I think to answer your question, which I've went the long way, it dispelled this notion that there's a climate refuge. There was talk about Asheville being a climate refuge, people coming from California to escape extreme weather. No geographic location is immune. So that's like my baseline. And I think, yeah.
Thank you so much. Beyond the climate data and projects that we've been working on, what else are we working on? I don't know if you want to mention some of the things or I can mention some of the things. Um, all of our data and research is on our website at WNCHN.org. If you go to the resources section, you can drop down to data and see some of the projects that we've done before, like our discrimination and health risk, our mediation analysis, our health trends. But what's coming up? Do you want to give people a sneak peek?
I'll give people a sneak peek. I'll do my best because this is what I really love to geek out. Helene wasn't on our radar, Joe, when we pitched this work to
Oh,
NIH, what, a year ago or a year and a half ago, because it takes forever to get federal funding. So Helene wasn't on our radar, and we have, as of late November, been able to secure NC Detect, which is syndromic surveillance data from emergency departments. We have been doing a number of post-Helene analysis, kind of using Helene as a natural experiment and looking at those 3 months. We only have 3 months of data. There's a long latency, as we all know, to actually obtain these data. And here's sort of what we found. We looked at primary care sensitive conditions. And we saw a pretty significant increase in adult populations for ED visits related to diabetic complications, dehydration, and other preventable, avoidable visits if primary care were readily available. We've seen a pretty significant, as you would expect, increase in ED visits related to anxiety. We've gone on to look at specific populations. I care deeply about women's health. So we've been looking at maternal and infant populations, looking pre-post changes for a number of pregnancy complications, including hypertensive disorders of pregnancy, gestational diabetes, perinatal mood and anxiety disorders. And for me, this was really startling. And the 3 months after Helene, we saw a 31% increase in perinatal mood and anxiety disorders for pregnant individuals. This increase was especially pronounced among our Black and Hispanic residents and food insecure. And we translated the upwards of 183 excess cases due to Helene into economic dollars. And what we found was just for this condition, perinatal mood and anxiety disorders, Helene excess cases resulted in upwards of 3 million additional dollars in cost. And so we're working to kind of take the data and these increased risk in that 3 month period, translate into economic cost, and then see if we can move the needle on some recovery, policy planning, patient interventions, community level interventions. And I'll say lastly, we know that economic hardship tied to these disaster events is acutely linked to intimate partner violence. And so we've started a study looking at pre-post changes in intimate partner violence, child maltreatment, and elder abuse. So stay tuned. We hope to have results out in the next couple of weeks. And Joe, I would love to partner with you and the Health Network to kind of get out some of this data just for local and regional decision makers to start taking it in.
Absolutely. Well, thanks, Jen, for being here today. Hopefully we can have many more conversations about data and maybe people listen. We'll see.
I'm so game. Thank
All
you so
right.
much for extending the
Thank you.
invite.
All right. Bye-bye.